I know you've done this in the previous semester, correct? Okay.
Fundamental, yeah.
All right. So let's review only post-op care. So this is not any different from any chapter, meaning this will apply whenever there is a surgical option on any given chapter, including chapter 23, right? So in acute coronary syndromes, we did two surgical options, right? We had the PCI and then we have the CABG. So this one will apply in addition to the mediastinal tubes and the pacemaker wires. All right. So post-op care. The post-op period begins from when the patient's last incision is closed, meaning whether that incision closure involves staples, glue, or sutures, that is the end of the intra-op period. So again, post-op period begins officially once the last staple or the last suture or the last glue is applied to the incision. Post-op care begins. So the first unit the patient enters is the PACU, post-anesthesia care unit. Even though you are not expected to be ICU nurses fresh out of graduation, you will be expected to know basics of post-operative care because PACU nurses have the same credentials as ICU nurses. So if you're a PACU nurse, you can float to ICU. ICU nurses can float to PACU, vice versa. We will not talk about the phases of post-anesthesia care. Again, are you a PACU nurse expected to be a PACU nurse? No. So we'll just do the basics. All right. First scenario will be you're the post-op floor. So you're on orthopedics maybe or regular med surg, wherever your unit is. You will receive report from the PACU nurse. That report, that handoff must contain the following. So patient's name, gender, age, allergies. What did they have? What was the procedure? What was the position during procedure? Position is important because when we look at injuries sustained during surgery, for instance, if the patient received general anesthesia, do they have any control over how they're positioned? Can they say if they're having any discomfort or feel like their arm is overstretched or they feel like their arm is broken? No, because you sedated the patient, you paralyzed the patient, correct? So patient during surgery receives 3 medications. One is the general anesthetic, which is a gaseous form. Second is opioids, because we don't want you feeling the pain. Third are paralyzing agents, or also known as neuromuscular blocking agents. You've heard of succinylcholine. Okay, so those are the drugs we use to paralyze the patient. Because can we have the patient scratching their nose or their belly during the surgery? Okay, because we paralyze them, can they breathe on their own? Can the diaphragm move? No. So do we intubate them? Yes, we put them on a mechanical ventilator. We intubate. So during position, depending on how the patient was positioned, they can sustain musculoskeletal injuries because again, they have no control over their muscles. They're at the mercy of whoever is positioning them for the procedure. Length of time, how long were they on the table? So that will tell you also the length of time they were exposed to general anesthesia. Or what anesthetics were used? Or did they have an overdose? And if they did, what was done, what was given, what antidote were given? How much blood loss, if any, did the patient sustain? And if they did they receive any blood transfusion or any blood product? What's the latest vital signs? This vital signs must be taken in the last hour from when you got report. Okay, it shouldn't be like from 2-3 hours ago. You need a fresh. If they don't have one, please politely ask. Can you just take No, take 2 minutes, get me a fresh set of vital signs. Is the patient awake? And if they are, what discomforts are they voicing? Are they nauseous? Because are these common after surgery? Yes, because is there peristalsis after surgery? So this, remember, this applies to any surgical procedure, okay? So this could be the cath lab person we just talked about before the break, or the cabbage person before the break, right? So same miserable complaints, okay? Nausea, vomiting, I feel bloated, I'm in pain, right? I'm constipated. Same complaints for every post-op patient. Any complications? Were there any? Did the patient fall out of the operating room table? Okay. Did any body parts come flying? Right? Or did we cut off the wrong appendage? Did we, is the right patient we were supposed to do surgery on? Right? Any medical comorbidities? This is referring to any chronic illnesses. Is the patient diabetic? Does the patient have COPD? Patient have heart failure? Are these relevant? Yes, because you have to take over this patient's care, so you need to be aware of what the other problems are. Allergies. With medications given here for these problems, let's say there was pain. You need to know if it's pain, when was the last time they were given? Because you know this patient will complain of pain, correct? And you need to know when can you give the next dose, right? Because really, let's face it, post-op patient, are non-pharmacologic pain interventions really going to work for a post-op patient? No. Probably later, a few hours later, but not fresh out of the operating room. They will benefit from the medications, most of all. Are there any language barriers? Okay, what language does the patient speak? Where are the family? Because what will this family be looking for? Yeah, they'll look for the patient. There will be also some special requests. Okay, let's say, is there anything else I need to do? I need to know. Let's say regarding to the family, do they want us to call someone when they're ready for a visitor? Or let's say, how is this patient's mental status, right? Are they oriented, or are they confused? Do they grab pieces of crap and smear them to the staff? Okay, you would want to know these details, right? Otherwise, you'll find out the hard way. You already have a crap full of crap smeared on your mouth. All right. So when the patient comes, always look at the patient. Patient will come in with some equipment. There'll be IV pumps, IV fluids running. So look at the patient first. Then take vital signs as soon as you receive them, and then compare it with the vital signs that was given to you. That way you make a comparison and see if they're stable, if you need to notify someone as needed. So you go system by system assessment, just like any other new admission. So you start from respiratory to cardiopulmonary and then go down, okay, neuro, skin, and then when you get to skin, look at the surgical incision. Now, not all patients will have a visible surgical incision, because let's say in orthopedics, those orthopedic surgeons are very protective of their incisions. They don't want nurses touching them. So they use 7-day or even 14-day dressings, meaning that dressing stays for how long? 7 days, 14 days. You're not allowed to take them off, right? Unless they come off on their own. Let's say they loosen, then you have no choice. But they have, each surgical team have their own pet peeves, for lack of a better word, right? So they're very protective of the patient over their incision. So they'll have, just follow agency policy if they want you touching their dressings or if it's exclusively them, right? But again, go head to toe, but prioritize respiratory and cardiac assessment. And of course, vascular, because remember, with every bedridden patient or decreased mobility patients, what could always go wrong? Blood clots, what else? Let's say they did throw a clot. So where will that clot go? PE, heart attack, or stroke. These patients were NPO, correct? Do you think they'll be hungry and asking for a burger after the surgery? Really? Have you seen patients like that, fresh out of PACU, looking for, hey, can I have a Carl's Jr.?
They don't ask for no. Well, they'll be
No.
drowsy, but they also ask for food.
Not all, okay? Especially general anesthesia patients. So they'll continue to be NPO. So depending on when they, even if the doctor orders a diet, say usually they start with a clear liquid diet. So on their tray, they'll receive broth, jello, juices, clear juices. But patients don't even touch them. So what will be your responsibility if they don't want anything? They're miserable. No. So what do you do?
Save it for later.
Remember, they've been NPO since midnight
Oh,
yesterday.
yeah.
Okay, so just assess your patient. Okay, when was the last intake? So if that's a concern, then notify a physician. Okay, ask for LR or IV fluids. Okay, hey patient, NPO last intake was yesterday. Okay, this is the blood loss, and then okay, before you even finish your statement, they know what you're asking for. Okay, start this fluids. All right. So advocate for the patient. Okay. Of course, again, prioritize. So ABC, airway first. How are they? Because remember, if they had general anesthesia, they were intubated, correct? So check the airway. Is there any signs of swelling, any stridor, any distress? Listen to lung sounds. And followed by the, um, again, heart. If you're on a monitored care unit, then check the patient's rhythm, the vital signs rhythm, and signs and symptoms of a blood clot or DVT. These are common. We just concluded shock last week, so I won't repeat that. This is in relation to blood loss, right? So look for signs of shock, hypovolemic, from hemorrhage or from simply fluid restrictions or fluid deprivation because of the NPO status. I'll skip this table. Really, hemorrhage is hemorrhage. But at least you should know hidden signs of bleeding, correct? So let's say you don't see any obvious signs of bleeding. How do you know the patient is bleeding? Let's start with vital signs. And oxygen and respiratory rate. Okay, very good, children. Pain management, use these appropriately. Always check the last administration, okay? Because before you know it, because what happens to this patient's kidney function? Because of all the blood loss, fluid deprivation. So could they develop AKI after surgery? It's possible, right? So what will happen to drug excretion, drug elimination if they have? Okay, so that's what I mean by check the last administration, okay? And then check kidney function. Are they able to eliminate the drugs normally? Because before you know it, your patient's overdosing, right? Although you already have it in your MAR, because it's standard post-op, if you have any narcotics ordered, any opioids, they also order the reversal agent. So you'll have naloxone also there. And what's the antidote for, or the reversal agent for benzodiazepines? The first two syllables are correct. Flumazenil. Okay, flumazenil. Or no, you combine romazicon and flumazenil. No, flumazenil is the generic. Romazicon is the brand. I think you said you said flumazicon. Flumazenil. Okay, it's flumazenil. Anyway, so post-op nausea vomiting, this is common. So your patient may receive multiple antiemetic agents, meaning not just one. What's the most common, antiemetic? Okay, that's what people always say, ondansetron, correct? But Remember, if you look at the action of ondansetron, is it really for acute nausea or is it for preventing nausea? The action actually is prevention. So therefore, they're having acute nausea. Is ondansetron going to help them at all? Maybe for the next nausea, but for this nausea, acute nausea here, will ondansetron do anything? So you're going to have to ask for something else. So you can ask for Emend, for instance, which is aprepitant, or let's say metoclopramide. For me, metoclopramide is the best because metoclopramide is, yeah, right here. So table 16-2 for nausea. This drug is a GI stimulant because what happens to peristalsis post-op? Decreases, right? Whether or not it's an abdominal surgery, there will be decreased peristalsis because of the medications. So this for me is the best drug for post-op nausea vomiting because look at how it works. It stimulates peristalsis. So therefore, it does two things, right? So it relieves not only nausea but bloating, right? And then promotes bowel movement, right? Because these patients can get constipated also, correct? Right. So for me, it's this one. Or if you have nothing else, so let's say this patient has, especially if you have no IV access for whatever reason, they're hard stick, and then can you give anything oral? They're have nausea? No, right? They'll just vomit. So this one will be great. Flucloperazine comes in rectal. So you go suppository. Say this one, phenothiazine. We used to give this for a while. It went out the market because the IV route caused a lot of vascular complications. So this was out of market for a while, and I don't know what happened, where it's back, but I know between 2005 to 2010, it was off the market. Dimenhydrinate, similar to your motion sickness medications. Hydroxyzine or Atarax, you may have heard of Atarax. So that's, or Vistarel, that's hydroxyzine. And scopolamine comes in a patch, you put it behind the ear. And ondansetron, your favorite. Okay, so look at the action. This one prevents, okay? So clearly prevention of post-op vomiting. So how do you administer it? For acute nausea or in advance? Advance. Same thing here also, prevent. What about this one? Okay, so this is for acute nausea. How about this one? Prevention. How about promethazine? Acute flucloperazine. Acute toclopramide. Acute as well. Okay, so use the appropriate one. If you don't have all of these ordered, then ask for it, right? The worst the doctor will say is no. So give me a single most effective way to prevent all the complications of post-op patients. One thing that will prevent everything else. One thing, one intervention, which not a drug, an intervention that can ambulation, early ambulation. Yes, these patients will be acting like babies, right? No, hurts. Okay. So do what you can to encourage them out of bed. They're complaining of pain, then give pain medication, but get them out of bed. They don't walk, at least get them out of bed into a chair, right? Because that's a start. Then they'll be forced to, of course. How do they go back to bed? They have to stand up somehow, right? So the earlier you ambulate them or encourage them out of bed, then will there be any blood clots? Will there be any nausea, vomiting, constipation? Will there be any pneumonia, UTI? No. So get them out of bed as soon as possible. Even bariatric patients, okay, or especially, I should say, especially bariatric patients. Patients will act like babies, okay, when sick. I do, okay, whenever I'm sick, that's how I behave. Right? But you shouldn't tolerate that. Show compassion, but then do not, what's the term? Something better than that. Do not, don't put up with it. Okay, get them out of it because you're the one actually that will suffer. Because if this patient suffers any complications because they stayed in bed, whose problem is it?
Yours.
You're still on the clock, right? So if I get them out of bed, I know they won't have any of those complications on my shift. For the next shift, that's their problem, right? If they tolerate the patient's non-compliance. Plus, the doctor will always take your side because they want the patient to walk. For discharge, depends really where is the patient right now. For discharge, if you're in the PACU, then the discharge really is to a med-surg floor. If you're on a med-surg floor, there are two places the patient can go, either to another facility for rehab or home. Home may or may not require follow-up, but almost all patients require follow-up, except for younger people, let's say, routine appendectomy, they're fine. But let's say orthopedic surgeries, spine surgeries, so they require follow-up. Okay, don't worry, your surgeon will already write orders for that. Okay, for let's say home health care or home PT. And here's the discharge. So you give them basic instructions, detailed instructions on what restrictions should you include. Activity, right? There are activity restrictions. With activity, what are we really talking about? Driving, lifting, right? What else? Activity, right? So can they go running? Okay, when? Okay. When you say swimming, okay, when can they get the incision wet? Because it really depends. Well, on the surgeon preference and also the location. For instance, it's an ear surgery. So can they take a shower? No, right? Yeah, they're supposed to cover it. What about eyes? Okay, so what are the restrictions? Okay, so specific to the surgical procedure or the site. Follow up. When is the follow up? Is there someone who can they stay at home? Okay, who can take care of them at home? Who can change the dressing? What do they need to report? So what would you include in the instructions? Okay, signs and symptoms of complications, which are what complications again? Fresh post-op patient. Okay, so let's start with the surgical wound. So what are signs of infection? Bleeding, because meaning for drainage, the incision, what is the color of the incision that's expected after surgery? Sanguinous, which means bloody. Okay, red. What's next? No, that's for the vagina. For any other incision, so we have sanguinous to serosanguinous. So from bloody to now cranberry, right? Semi-bloody, and then finally, again, that's the vagina. So we'll do the serous, right? So just clear drainage. Okay. So let's talk about, well, how many days is it supposed to look bloody?
Not like a one.
1 to 2 days. Okay, it should not be bloody anymore by the third day. Okay, so if it's still bloody, that means is the incision healing?
No.
No. So that occurs when patients have either malnourished or really old patients. Okay, but after 2 days, it should not be bloody anymore. It should change to serosanguinous already. When should it stay serosanguinous? So we said bloody from 1 to 2 days, so therefore third to the fourth day. Okay, so serosanguinous. And then, of course, the amount should be decreasing. So any significant bleeding or drainage on the 5th day, is that normal? No, something's wrong. If it continues to drain a lot, then What could be causing a non-healing wound? What could be in that incision?
Yeah.
Infection, or what else? When we say infection, what could be causing the infection? Could there be some instrument there? Maybe there's a sponge left, right? So consider that, right? Or let's say if it's not, because surgical incisions, should they be infected? No, because we practice strict sterile technique. So any respectable hospital practices good sterile technique, right? So surgical wounds are not usually infected, right? If they do get infected, when should it occur? After the 5th day. Okay, that's usually either the patient's getting discharged or already at home. Because they should not be infected. Unless, of course, the patient has certain risk factors. So let's say obese patients, and the incision is in the groin. What's the expectation? Of course, that thing is going to be infected. All right. Can you clean really that area? And then the patient has like 400-500 pounds on them. And then just imagine what the groin will look like. All right. So not, not really ideal, but we do that for some bariatric patients who have, say, vascular problems, or let's say they have ulcers on the leg. Okay, and then we do bypass surgeries, which is always in the femoral. Anyway, so that's it for post-op care.